For us at Cabrini, I think we take the view that when you have a life-limiting illness, that it's important that we incorporate such conversations into routine care. So advanced care planning is seen as a process that evolves right through the spectrum of your care when you come into contact with particularly our service. So for example, we recently developed an admission form for patients, and any patient that's newly admitted into the service goes through a series of questions about their medical condition or the symptoms they might have or their psychosocial issues. And at the end of the form, we then try to elicit what somebody's future care plans might be. Now, prior to engaging with that conversation, it's really critical that you do some exploratory questions or take some time to assess readiness, to see if somebody is actually ready for such conversations. And it's a simple process of asking someone, like, if you got sicker, where would you like to be cared for? So eliciting a preferred place of care. And from then on, you can go on to have further conversations about if you then were cared for in a particular place, or what are the sort of things that you would like us as your professional caregivers to pay attention to. What are the things that are important to you? Who are the people that are important to you? And what are some of the treatments that you may not have considered? And I think most importantly is it has to be incorporated into the broader conversation that you might have with a patient as you admit them or you're visiting them either at home on a daily basis. I think that's an important point, to recognize who are the staff who do have the skill set and who are the staff who need to develop the skill set, because I think naturally assuming that everybody should do it might not necessarily be the right approach. There needs to be a process of training your staff and providing them with an opportunity through role play or engaging in teaching or resource material to feel prepared enough, because they can be sensitive conversations, and you must also have the knowledge base and the skill set to know how far to take a conversation and what sort of information to provide, and more importantly when you might need to defer parts of the conversation to another member of your multidisciplinary team. So for example, a nurse caring for somebody late at night might have an encounter where somebody might express a fear or a concern about the fact that they may not return home, and that's where they want to have end-of-life care, or the fact that they might be having treatment that might be prolonging their life unnecessarily. And I would say that it's the nurse's role, if they feel they're appropriately trained or able to take that conversation to some level, but with the patient. Yes. But very importantly then in the following morning to then defer it to the other members of the team. We could be the physician caring for the patient or the pastoral care person, so that the conversation is followed through, and there is further opportunity to explore and very importantly to document. And documentation doesn't necessarily mean documenting in an advanced care plan in itself. It could be simply documenting it in a set of notes, or for nurses who are working in the community, in their daily community notes. There needs to be a process of education for any staff or any organization or unit about the legislative issues around advanced care planning, because there's some documents that are held in law. So for example, if a patient completes a refusal of treatment certificate, there needs to be a recognition that that's a legally binding document within the state jurisdiction that you live in. There's also an importance for staff to understand that a written statement is not necessarily legally binding. It might just simply be a statement of wishes, and that when somebody walks in with the document, it's very important that you clarify that these wishes are still current and people still feel the same way. And secondly, that you provide an opportunity for revision. So any staff that walks in, any member of the team has an opportunity to review the document, to be aware of what the statewide or national legislation is surrounding the documents that are completed, and then provide an opportunity for these documents to be discussed within a multidisciplinary team setting. And also very importantly, I think for organizations or units or departments to have systems in place, structures and processes. Where do you file these documents? How do you alert staff members that might be moving through your unit, coming in the evening shifts or night shifts or daytimes? How do you alert them that these documents are present? How do you then review documents with these patients? And very importantly, how do you provide opportunities for people who don't have documents or who haven't completed advanced care planning to actually consider them? I think it's important that you familiarize yourself with the plan first, that you spend some time reading it and also correlating what might be written in the plan with what you know about the patient's condition. The patient's clinical condition. So sometimes people might fill in plans and not necessarily fully understand the implications of some of their decisions. So for example, it's very common for people to say to me, I don't want to have antibiotics, or I don't want to be sent into an intensive care unit if I ever got seriously unwell. Now in some conditions, particularly for example in cancer care, treatment has become very complex. So somebody might be on chemotherapy and might get very unwell with an infection and might even lose capacity to speak for themselves in these instances. But we understand that the illness that we are seeing is actually the consequences of treatment that they're getting from a treatment that's used to improve their symptoms or potentially prolong their living. And in these instances, getting antibiotics is very appropriate. Or a short stay in an intensive care unit to just get them over a period of sepsis is appropriate. And it's very important to talk to families about these things, to say, well, even though we don't want to prolong your life unnecessarily or inappropriately, in instances like this, acute medical treatment is important for maintaining your quality of living. So a lot of time advanced care plans are written based on what we potentially foresee for the future without the actually lived experience of an illness. So many patients would say to me, I don't want to be in a wheelchair, or I don't want to have feeding, tube feeding, or I don't want a period of care in an intensive facility. But the reality of what occurs when you're actually in the moment of an illness experience is very different. Human beings have a tremendous capacity to readapt, to recalibrate, to achieve what we call in psychology terms a response shift, where there's an internal recalibration of values or constructs which are important to us as we get sicker, and a tremendous capacity to adapt. Therefore, always reviewing advanced care plannings, reviewing values, reviewing what is important to you at a particular moment of time is critically important. Certainly from my experience of working with many young patients, particularly within the cancer setting, talking about end-of-life wishes in somebody who is in their 30s or 40s, who might have a family, who has financial responsibilities, or is very, very different from talking about it to somebody in their 70s or 80s. So a one-glove-fit-all approach is not appropriate. Some preliminary research that we have done has also showed that people make choices. Some people want to actualize advanced care planning, so they want to proceed and actually complete the documentation. Okay, and even then, it is the term a process is used because it's now increasingly recognized that it's not a static process; it's a dynamic process, or what we call an iterative process. So people vacillate. They want to think about it, they want to leave it alone, they want to talk about it, they don't want to go there, they might want to take it so far, they want to leave it for a week. So just like behavioral change models when it comes to anything like giving up smoking or making lifestyle decisions, you have to allow patients or families time for that iterative process to go to occur. Some people will actualize it, some people will relinquish it, some people will say, these are really important issues, but I trust my families to make these decisions for me. I don't want to talk about it. Some people will reject it, will say, actually, this is not an area I want to talk about at all. And I might defer to my physician to actually make the decisions they feel appropriate at a time. And we have to respect this. And we must also remember that people might choose to relinquish or to reject the process of advanced care planning, but then subsequently choose to return to it. So a static, dynamic process of ongoing conversations, allowing adaptability and flexibility is really critically important, and staff need to be aware of that. Resourcing needs to allow for that. So allowing somebody or providing people a single opportunity to complete an advanced care plan is not the right approach. Research has shown us that positive outcomes arise when you provide ongoing verbal information, particularly verbal more so than other levels of other kinds of information, over repeated periods of time by multidisciplinary groups of people. Not singular people, but you have many people. You might talk to a pastoral care worker or a nurse about things that you may not talk to your doctor about. So it might be a very different situation in a nursing home where you don't have that level of resourcing. But on the other hand, you can think of training of a number of different nurses. You might also be very importantly include general practitioners that visit nursing homes to be part of this process or engaging, but not restricted to singular individuals or individual groups of people. I think asking people to think about specific medical interventions is very difficult, because the reality is the decisions that you make vary so much based on the type of diagnosis that you have, or the time of at which you're diagnosed, or the stage of the illness that you might be experiencing at a particular period of time, where you might be getting care, whether it's in the community or in the hospital, whether it's in a rural or an urban setting, the resourcing that's available to your care. All of these factors influence the outcomes that occur. But I think very importantly for people to think about what's important to them. What are the things that guide the way they want to live and also the way they want to die? I think most organizations should have a delegated person to oversee something like this. So in our department, it would be 2 senior social workers who are specifically trained. So even though conversations might occur across the team and decision making or formulation of plans might occur with different members of the team, the final task is delegated to a single person who then sees through the completion of documentations, if there are formal documents required, the formal appointment of medical enduring power of attorneys, the ensuring the translation of plans if there are legal issues directly into care. So I think having a singular appointed person to oversee the operational processes around advanced care planning is critical. The broader issue of who to have conversations with is one that should involve as many people that we feel or deemed appropriate, particularly people who are trained, as possible. So talking about resuscitation with people who are actively dying is very confrontational. And for many young, untrained staff or inexperienced staff, they might take the approach of going to a patient and saying, would you like cardiopulmonary resuscitation in the event of your hearts? And that's very confronting. So you're basically asking somebody to forego an opportunity of ongoing living. So I think eliciting a patient's preference is critically important. It's how you do it. It's your choice of language and words, and sometimes in the process of an ongoing conversation about how unwell somebody might be, to simply state, if by natural circumstances your heart stops beating on its own accord, or your lungs stop working, what would you like us to do for you? Some people might state that I would want active resuscitation, which involves pressure on your chest. And some people would say, let nature take its course and just keep me comfortable. So I think talking to patients about it is important, but it's how you talk to patients about it. And it's also important to recognize that for some people, such conversations can actually be counterproductive or can even be harmful. So patients who might have high levels of existential distress, patients who might suffer from depression or anxiety, patients who might have cognitive impairment where they don't have the ability to process such conversations, I think there needs to be caution and also maybe a more sensitive approach to how we elicit these preferences. So if you're caring for people with serious illnesses, the concept of having cultural competency or cultural awareness is critical, and your staff must be trained in that, in the practices or the beliefs or the wishes of people of different ethnic groups, not just necessarily religious groups. So for example, where I work, we have a large Jewish population. Where I've worked elsewhere before internationally, I cared for people with large ethnically Asian backgrounds. And in some of these cultures, having end-of-life conversations were considered taboo. It might be considered that you might bring death on somebody. Issues of collusion might become very prominent, where family members ask that you don't disclose information to patients. Saying all of that, it's still possible to elicit preferences. It's how you do it with sensitivity, and I think very importantly you take guidance from the families. And I never have these conversations without family members' presence. So the families take the lead. The families understand why it's important. They are present when the sensitive conversations are asked, or if they are present and they actually witness a patient asking about prognosis or about a diagnosis, they can understand the importance of this to the patient themselves. And there's a process of inclusion where the families are included within that conversation. But cultural competency and cultural awareness is critically important. When people are alone or people don't have an identifiable next of kin, I think it's still still possible to make people feel that they belong collectively to something or somewhere. And it could actually be the organization that you work for. You are their family, you know. And my view always is that nobody should ever be alone when they die. That there's always somebody around to accompany you in your process, to accompany in your decision making. If I have to have these difficult conversations, I never do them on my own. I always have somebody with me. So it's usually a nurse or a pastoral care worker or a social worker. So the patient doesn't feel the burden of decision making, and there is a second counterpoint to actually validate what the patient might say or what your views as a professional might be, and there is a second sounding board. And more importantly, when you leave and you walk away from that conversation, there is somebody left behind for that patient to feel supported by or deferred to. So even though somebody may not have an identifiable next of kin, they should never be alone in their living or ever alone in their dying. There's always enough of us to go around. And the most important thing is you create a space or an environment for these conversations to occur. And that's done by making sure that the setting is right, the time is right for the patient. And I always say the most important things for a good consultation are your hands, your eyes, your ears, and a chair. And you give an indication to somebody that you're giving them time, and you very gently and slowly start a conversation, because sometimes you don't have the opportunity. People are very sick, and you very quickly need to elicit what their wishes are. And creating an environment through the tone of your voice, the posture that you take, the sensitivity of the language that you use can actually allow for some of the most sensitive, and I use the term magical, conversations to occur. And even though others are present in the room, it feels like it's just you and the patient. And they can elicit their greatest fears or anxieties or worries to you. And with that information, you can help them formulate a plan, making them aware that the control always remains with them and with their family. If things change, we are flexible. If they're unsure, we revisit.